Can you see?
Yes.
Okay. So today we will study about osteomyelitis of jaws. Okay. Since it is a very important topic because of it can mimic many of the other diseases. Okay, like periapical lesions or dry sockets and all. It can mimic clinically as well as radiographically. So we'll cover this topic under definition, basic structure of bone, vascularity, alteration in vascularity, predisposing factors, etiology, pathophysiology, microbiology, incidence, then classifications, clinical features, histological features, radiological features, and bone scintigraphy. Then what are the principles of treatment of osteomyelitis, antibiotic regime, surgical management, role of hyperbaric oxygen, types of osteomyelitis, rare case reports. Okay. So by definition, osteon means bone, not osteum, our implants. No, osteon means bone, myelose means marrow, and itis means inflammation. Okay. So osteomyelitis may be defined as an inflammatory condition of bone that begins as an infection of medullary cavity and Haversian systems of the cortex and extends to involve the periosteum of the affected area. Correct?
Correct.
So it begins as an infection of medullary cavity. Okay, it will begin as an infection of medullary cavity. Then it will go to Haversian system and then to the cortex. So it starts from inside.
Yeah.
So what is the structure of bone? The bone marrow is made up of cancellous bone, which is rich in the osteoblastic precursor cells. Okay, and the reticuloendothelial cells, erythrocytes, granulocytes, and platelets. It is highly vascular. A cortical bone is covered by periosteum. Okay, this is a structure of the cell, bone cell, like osteocytes, osteoclasts, and other lacuna, intestinal laminae, caniculi. Then the cortical bone is made up of dense bone which contains well-organized trabecular system connecting to bone marrow with cortical bone. It consists of longitudinally oriented canals. These canals, can you see? Haversian. These are called as Haversian system or central canal having nutrient blood supply. Haversian canal system. Okay, it gives blood supply to the osteocytes which are lodged in the cannulae. Then there are Waxman canals that connects to the Haversian system to each other. Waxman canal also connects to the bone marrow and periosteum which envelops the cortical bone. These well-organized, complex, interconnected system provides nourishment for repair and regeneration of the bone. Now its vascularity, the primary supply is inferior alveolar artery and temporalis muscle vessels. Okay. Secondary supply is periosteal supply, which run parallel to the cortical surface of bone, giving of nutrient vessels which penetrates cortical bone and anastomose with inferior alveolar artery. Okay. So two supplies are there. First is inferior alveolar artery and then is periosteal supply. Okay. Clear?
Yes.
We're talking about the mandible. Maxilla is rich in blood supply, so need not to worry about osteomyelitis. It's very rare in maxilla, but in mandible, yes, it resembles as a long bone, so it happens in mandible. Okay. Now, alteration in vascularity. In 1943, the vascular Waldron state that the vascular morphology, the mandibular vascular support has been provided through the multiple arterial loops from a single major vessel, which renders as a large portion of bone susceptible of necrosis with occurrence of major vessels and infection thrombosis. So, did you observe that the mandible contains this inferior alveolar canal? It comes like this, and then it makes a loop. In the mental region, it makes a loop like a hairpin fashion. Okay. So here is the thing that any stagnation in the loop or anything which is in the loop, it may have a rendered supply. Okay. In 1970, it was suggested that the segregation of vascular channels, which is like end organs. So this is like an end organ. Okay, because it ends here at the mental foramina. Are you getting it?
Yes, yes.
So due to lack of terminal collateral anastomosis, ultimately leading to the vascular plugging by the bacteria and microthrombi or both. When afferent vessels anastomose with medullary channels, there are possibility of decrease in venous flow associated areas of the greater turbulence. So reduction in the host immune defense mechanism associated with these vascular channels in calcified tissue. Now, what are the predisposing factors for OML or osteomyelitis? The conditions reducing the host defense. Now, this is the major factor in case of COVID also, this is there. Okay, so host defense like diabetes, anemia, sickle cell anemia, tuberculosis, malnutrition, agranulocytosis, leukemia, chronic alcoholism, and febrile illness. The condition compromising jaw vascularity, radiation, Pagets disease, osteoporosis, osteopetrosis, then fibrous dysplasia, peripheral vascular disease, malignancy. Now, etiology. Why malignancy? Yes.
The growth, malignancy of the bone, is it?
Yeah. So in malignancy, what will happen? There is new vascularization. New vessels will be formed to supply the tumor. Okay.
Yes.
So
Yes.
all of the supply is going to the tumor. So bone will be deficient in bone will getting deficiency. Yeah. So that's why bone will turn into bone will go for necrosis, because all the blood supply it is sucked by the tumor only.
Tumor.
Okay.
Yes.
Now in etiology, odontogenic infections are there, compound fractures of the jaw, traumatic injury, middle ear infections, respiratory infections, furoncosis of the chin also, then peritonsillar abscess. Now what is the pathophysiology of the what is the sequence? What is the cascade? It is first infection or trauma is there. Okay. Then there is acute inflammation of the bone. Then hyperemia is there, increased capillary permeability will be there. After that, infiltration of the granulocytes are there. Then they will liberate the prolytic enzymes and it will lead to vascular thrombosis. So this is a very beautiful cascade. Okay, it liberation of prolytic enzymes and it will go for vascular thrombosis. Then when vascular thrombosis is there, deficiency in the blood supply, it will go for tissue necrosis. After that, when tissue necrosis is there, since blood cell contains all the white blood cells for fighting for infection, so there is no blood, no white cells. What will happen? Infection will raise and pus accumulation will start. Okay, pus accumulation. Now you understood why pus is there in some cases, because there is a bone necrosis with a high pressure or with extensive pressure or anything. The bone necrosis is there. In our case of implant, you remember you were saying that pus like
yes. Yes.
Yeah. So why the pus accumulation is there? Because of pressure, there is bone necrosis. Okay. So now due to bone necrosis, what will happen? Small infection site will come. So when you silently cure it or leave it like that, the bone will grow because it is not in pathologic state. It is not in pathologic state. So there are chances that it will grow again. Just over that tissue massage that not in case of osteomyelitis, but yes, in case of implants.
Yes.
There are chances that the bone will grow back. Okay. So there will be increased intermedullary pressure. Now there will be vascular collapse and venous ischemia. The pus travels through Haversian system and accumulates beneath the periosteum. The pus travels through the Haversian system and accumulates beneath the periosteum. See, these are all cases who are medically compromised, okay, not on the healthy persons. Then compression of the neurovascular bundle, thrombus ischemia, penetration of the periosteum. It will come through periosteum now. And mucosal and cutaneous abscess will be there. Increase in the natural host defense treatment phase, the chronic osteomyelitis inflammation regresses. The inflammation will reduce because there is a pathway of the drainage for the pus. The granulation tissue formation and there is new vascularization there. Okay, and this new vascularization will supply all the granulation tissue and all. That's why when you curate, the granulation tissue bleeds like anything. But when all the granulation tissue is out, bleeding stops. Have you observed in curettage of any tooth or all infected tooth? If you have extracted any infected tooth, you will see the bleeding is coming out. Okay, and when you curate the socket with the lightly curate the socket and all the granulation tissue comes out, after that the bleeding will stop. Sometimes granulation tissue tag along with the root also, and it comes out, and sometimes you have to curate it out. Okay. Then there is bone lysis fragmentation and sequestrum is formed. Now, what is the microbiology? Microbiology is what are the various organisms involved? The Staph aureus, Staph albus, hemolytic streptococci. These are the main three. Then in gram-negative, we get Pseudomonas, Proteus, Caspilla, and E. coli. In anaerobic organisms, Streptococci, Peptostreptococci, bacteroids, and Fusobacteria. Fusobacteria is mostly found in the root canals also. Okay. Then Mycobacterium tuberculosis in some cases, and Treponema pallidum and A. israeli. Now, what is the incidence in various bones? In maxilla, it is rare due to extensive blood supply and significant collateral blood flow in mid phase. The porous nature of the membrane bone, thick cortical plates, abundant medullary spaces are there. In mandible, in premolar area, can you see?
Yes.
There is dense cortical bone. Okay, longer time for sinus formation. So the infection spreads, and there is spongiasia. So less vascular than maxilla. Maxilla is more vascular. The classification, historically accepted classification, is based on clinical codes like acute, subacute, chronic. Other classification on infection is specific. Then in specific, tuberculosis, syphilis, and actinomycosis is there, and non-specific is pyogenesis or necrosis. Now, in Hudson classification, the acute form of osteomyelitis, like in suppurative or non-suppurative, includes contiguous focus like trauma, surgery, or odontogenic infection. Then progressive in burns, sinusitis, and muscular insufficiency. In hematogenous, like metastatic, is developing skeleton in the children. In chronic form of osteomyelitis, the recurrent multifocal developing skeletal children accelerated osteogenic activities in less than of 25 years of age. Then in chronic form, Gary's osteomyelitis is there. Okay, you might have heard of Gary's osteomyelitis or getting a short note over there. Okay, then in suppurative or non-suppurative, it is inadequately treated forms like systematically compromised patients or chronic respiratory osteomyelitis. In diffuse sclerosing, the fastidious organisms and compromised host and pathological interference. Now, according to Wibgool's classification, it is based on the pathogenesis like hematogenous osteomyelitis, peripheral vascular disease, and focus of infection. According to anatomical location, intermedullary, subperiosteal, and periosteal. Presence of pus, suppurative and non-suppurative. So in suppurative, acute, chronic, and infantile osteomyelitis is there. And in non-suppurative, sclerosing, Gary's, and actinomatic and radiation osteomyelitis. In histological features, medullary spaces filled with inflammatory exudate. The polymorph nuclear leukocytes, lymphocytes, plasma cell. Osteoblasts bordering the bony trabeculae are generally destroyed. And trabeculae, they show slow resorption. The radiological features, there is Worth criteria. It is a moth-eaten appearance. Okay, moth-eaten appearance. Enlargement of medullary spaces is there and widening of Falkman's canal. Okay. The islands is that the sequestrum, a vascular necrotic bone which harbors microorganisms with evidence of trabecular pattern and marrow spaces. So you can't use a sequestra as a bone graft, okay, because it harbors microorganisms. Otherwise, you will say, okay, this is a type of bone also, we can use in a bone graft. No. Okay. Involucrum, it is a sheath of new bone which is often found separated from the sequestrum by a zone of radiolucency. Involucrum is the new bone formation. Now, stippled or granular densification of the bone by subperiosteal deposition of new bone, obscuring the intrinsic bone structure. So, radiological feature, it shows that you can see in this diagram and this comparison, areas of massive bone destruction. Areas of massive bone destruction. Okay, this is the hollowing of the whole of the mandible. Now in CT scans, it gives accurate indication of bone destruction, periosteal reaction, medullary destruction, and cortical.
Doctor, give me 1 minute. I'll be back.
So there is medullary destruction, periosteal reaction, and cortical involvement. Now these are the various CT patterns of osteomyelitis. Like what is the lytic pattern? Lytic pattern is destruction of the cortical bone and soft bone. So basically it starts from inside to outside. It is not from outside to inside. Osteomyelitis starts from inside of the canal to outside. Okay. Now this is mixed pattern. It shows osteosclerosis also and osteolysis also. Sclerotic pattern. Sequestrum pattern. In sequestrum pattern, whole of the mandible is normal, only one part is gone.
Yeah.
Now in MRI, most accurate compared to CT scans, it shows the bone marrow changes also and soft tissue changes also. And then there are specialized investigations such as bone scintigraphy, radionuclide scanning, physiological changes in the bone is seen, and the bone will seen as a metabolic thing, and the active blood supply, they can be seen in the scintigraphy. So in scintigraphy, this technetium 99 mm dye is used, given IV, and there is a scanner of sodium iodide. 3 phases: the flow study of 1 to 2 minutes, then blood pool study of 5 to 10 minutes, and delayed study of 2 to 4 hours. In addition to this, gallium 67 or technetium 99 aids in the distinguishing from OML from malignancy and trauma. In malignancy and trauma, these dyes also got blocked, but when you introduce gallium 67, it will not block in trauma or malignancy, it will block in osteomyelitis. Now, what is the decision tree in conventional radiograph? Positive osteomyelitis, stop. Negative osteomyelitis and high suspicion. Okay, then go for a bone scan. If positive, stop. If negative, then go for gallium-67 or indium 111 WBC scan. If we found a positive in that, okay, then stop. If negative, then again go for MRI or CT. If positive, stop. If negative, then also stop. Okay, this is the highest thing you can do. But by step, directly you are doing CT, you will not find anything because of the step-by-step process of introducing the dyes and all. You can find out. Okay, then what are the various principles of osteomyelitis? First is evaluation and correction of the host defense deficiencies. Okay, the main root. Then gram staining culture sensitivity, imaging to rule out the bone tumors, administration of the stain guided empirical antibiotics, and removal of the loose teeth and sequestra. Administration of culture guided antibiotics, repeat cultures, possibly placement of irrigation drains. Then antibiotic beads are there, because since there is no blood supply, if the patient is taking oral antibiotics or IV antibiotics, they will not reach
the site.
You will need a local antibiotic thing. So antibiotic beads are there, okay, which can be used. Then if the bone structure is sequestrum is formed and everything, then sequestromy, debridement and decortication, resection and reconstruction of the defect. So what is the main antibiotic regime in OML? Okay, the regimen in OML is the hospitalized, medical compromise, or when intravenous therapy is indicated, the aqueous penicillin, 2 million units IV, okay, then with metronidazole, when improved 48 to 72 hours, switch to penicillin 500 and metronidazole 500 for 4 to 6 weeks, okay, 4 to 6 weeks, or ampicillin with sulbactam IV for first 6 hours. Then when improved, switch to amoxicillin or augmentin, okay, for 4 to 6 weeks per orally. So first IV antibiotics are given for 72 hours. Okay, if there is an improvement, then you can switch over to per oral. Then regime 2 for outpatient treatment, penicillin V for 2G plus metronidazole, okay, for 4 to 6 weeks after the last sequestrum is removed. This is you are doing with the surgical therapy also. If you are seeing the sequestrum, then you have to remove it. Okay.
Okay.
Then clindamycin, okay, IV, and then after that clindamycin 300 per oral. Or cephalosporin. See, these all are given. The first drug of choice is given like penicillin. If the patient is allergic to it, or then you can shift to clindamycin. If allergic to clindamycin, then you can shift to cephalosporin. Okay, and cephalaxin. Now in surgical, the processes are, first is saucerization. Okay, this you can do in clinic. Saucerization. In saucerization, what is there? As you can see in the diagram also, first periosteal flap is over. Then along with this, can you see the arc?
Yes.
The shape is bone is cut by, because the hematoma is not accumulated if you look at. Okay, so saucerization is done. So sequestra is removed, large hollow cavity, infected clot, reinfection. So you do a saucerization so that the clot will not retain in this position. Okay, and trimming of the dead space is there. So saucer shaped defect is created, and medicated dressings are given. And medicated dressings are given over here. Okay. Then next is decortication. The lateral and inferior cortex is removed. Okay. Irrigation and debridement is there, and trimming up to the bleeding point in vital bone. You will trim the bone until you encounter a bleeding point. Okay. Then next is resection and reconstruction. In resection, the complete eliminating of the infective process and reconstructed by the autologous bone grafts and reconstruction plates. Then role of hyperbaric oxygen, it involves the intermittent, usually daily inhalation of 100% of humidified oxygen under pressure greater than 1 atmospheric pressure. Okay. It reduces the hypoxia within the affected tissue and stimulates angiogenesis in hypovascular tissues. It enhances the phagocytic activities also and leukocytes to stimulate fibroblast growth, increase in collagen formation, and promote growth of the new capillaries. So now hyperbaric oxygen is a boon. So now it is not, why it is not commonly used? Because of availability. It is less available in some of the centers. They have hyperbaric oxygen chambers. Okay. In India, I think only 4 or 5 hyperbaric oxygen chambers are there. So this is a hyperbaric oxygen chamber. Okay. The patient is placed in the chamber. The oxygen is given by mask or by hood. Each dive is of 90 minutes length, 5 days per week for 30 to 60 or more dives at 2.44 ATA for 90 minutes while breathing 100% oxygen twice daily. So after hyperbaric oxygen, the patient will breathe the oxygen from the cylinder. Okay. So these are various protocols. Here, these are various protocols given by Marks and Milnes, that 60 sessions with 2 ATA of oxygen, and by Mansfield it was altering the 100% oxygen with intermittent oxygen followed by air to avoid oxygen toxicity. The protocol by Marks protocol, it is very well asked in the questions also. What is Marks protocol for hyperbaric oxygen? So initial 30 dives, if improvement, then 60 dives. This is the most acceptable protocol. Initially 30 dives, then if improved, then 60 dives are completed. Otherwise, sequestromy, and then again 30 dives. If wound dehiscence is there, then resection, again 60 dives and 20 dives after 10 weeks. Okay, so it is with the surgical treatment also. It is with the surgical treatment. So patient with pathological fractures like orocutaneous fistula are given 30 dives more prior to going to resection. Now the contraindications are in pneumothorax, you can't give hyperbaric oxygen. In COPD, optic neuritis, acute viral infections, and acute seizures, along with URI, pregnancy, thoracic surgery, ear surgery, malignant disease, you can't give oxygen, hyperbaric oxygen. Now, various types of osteomyelitis are infantile, acute, pyogenic, chronic suppurative, chronic non-suppurative, Gary's, and actinomycosis, tubercular, and syphilitic. In infantile osteomyelitis, the osteomyelitis maxillaris neonatrum is also named. It is very rare, and there is a disfigurement of jaw and involvement of cavernous sinus sometimes. The etiology is while at the time of delivery, there is a nasal cavity infection of involving maxillary sinus and hematogenous spread of first molar bud. So the staph aureus and pneumococcus are responsible. Sudden onset, high fever, redness, swelling over mid-face, poor urinary discharge below the median canthus of eye, subperiosteal abscess, draining sinus tracts, and poor feeding. The radiological feature, minimal bone loss because the child is too small, the sequestrum is there, and tooth burst is there. Treatment is broad spectrum antibiotics like crystalline penicillin, 2.5 to 5 lakhs units. Okay, and culture sensitivity and incision and drainage. Now this is a case of OML of maxilla with orbital abscess. This was taken from a bone because these cases are very rare. Okay, you can see the proptosis of eye. You can see the proptosis of eye. Okay, because of the pus accumulation here. Then we have acute pyogenic osteomyelitis. The pyogenic organ microorganisms are involved. The compromised host immunity. The etiology is odontogenic infections, periapical, periodontal, and pericorneal infections. Infections due to odontogenic cyst, tumors, peritonsillar abscess, extraction wounds, fracture jaw, use of contaminated instrument for surgical procedures. So this is a like iatrogenic. Okay, if you are using contaminated instruments. In radiological features, minimal bone destructions, no bony changes on radiograph because it's too early. Okay, then differential diagnosis may be a surgical defect. Treatment, rest, adequate nutrition, high calorie diet, then dehydration. If dehydration, then IV fluids are there and analgesics. IV antibiotics, empirical, culture sensitivity. First empirical is given, then culture and sensitive these are given, antibiotics are given, and they are changed as required. Drainage after the acute phase is over, yes, you can do the drainage also, and removal of the foci means if the tooth is involved, you can remove it. Now, how can you differentiate between a dry socket and an osteomyelitis?
Dry socket, I think it happens within 3 to 5 days.
What is the basic feature, clinical feature? If I will show you 2 radiographs, okay, one is of osteomyelitis because there is no typical change in the osteomyelitis, and one is of dry socket. In dry socket, there is no change in the radiograph. Then how will you differentiate? Very, very simple thing. Dry socket happens after extraction.
Oh, okay.
The tooth is missing in dry socket. The tooth will be present. Okay. Then give antibiotics, warm saline rinses, and adequate hydration. In suppurative osteomyelitis, the primary infection by subvirulent organisms, secondary if acute OML is not eliminated. So there will be a discharge, sinus, and sequestrum. Please pardon me for the photographs because these were taken with the DSLR and we got scolded with these things. So then radiologic features of chronic osteomyelitis is sequestra, okay, involucrum, and new bone formation is there. So try to show in this radiograph, maybe you can appreciate. Then long-term antibiotics, surgical sequestromy, saucerization, decortication, and supportive therapies there. In surgical complications, injury to the nerve, then pathological fractures may happen. Okay. In chronic non-suppurative, now the pus is not there. The pus is not there. That is more dangerous. You never know what is going on. So there are 2 types. Single localization means single localization, and extensive is diffuse cycloversion. The treatment is hard sclerotic mass is sectioned and curated carefully. Cavity packed with iodoform gauze, and antibiotics are given for at least 2 weeks. Now next is Gary's osteomyelitis. Okay, it is a non-suppurative. It happens in children or young adults. Then mandible is involved. Caries or soft tissue infection is there. Subperiosteal bone deposition is there. Radiological feature, cortical bone condensation and onion peel appearance. Okay. In Gary's osteomyelitis, if you are writing a short note and something, the examiner will just see the point, and if you have written onion peel appearance, yes, will give you the marks and go to the next.
I think I got this for my third year general surgery. My short note for third year general surgery.
You got a short note over it. Okay, nice.
But I don't remember now.
See, there is new bone formation here. In the back. Okay. Now the treatment is removal of the involved tooth, curettage of the socket, the contour of the extensive cortical expanded bone on only if it is obvious and facial symmetry it persists. you will, if the facial symmetry is distorted, then only remove the contour. Otherwise, if it is not distorting, then leave it. Okay, you remove the foci, rest everything will be taken care of. God is great. In actinomycosis, osteomyelitis, the rare chronic infection. So it happens with Actinomyces israeli or A. israeli in the normal flora. There are three types: thoracic, abdominal, and cervicofacial. So we are concerned about cervicofacial only. It invades through the soft tissue mucosa. So actinomycosis OML mostly happens in soft tissue. Then in clinical feature of cervicofacial actinomycosis is in mandible, soft tissue, parotid, maxillary sinus, tongue, extraoral swelling is there, purple and red fluctuate. Then sulfur granules, the serous discharge which is coming out, it will contain like sulfur granules. Okay, and there is a lymph node enlargement. Patient usually is not febrile. Patient is afebrile. In investigations, microscopy, blanching of filaments, then radiography and radiolation areas, laboratory finding, you will find increased ESR and WBC count, and culture and biopsy. You can pinpoint the actinomycosis. In treatment, incision and drainage of the pus. Okay, then IV antibiotics like penicillin, tetracycline for 3 to 4 months. Then surgical sequestromy later on. In non-cardial, this is resembled to the actinomycosis. Causative organism is nocardia asteroids, and without any dental injury, suppurative lesions with necrosis and abscess formation. Treatment is drainage and sulfonamide for 6 weeks. Then in tubercular osteomyelitis, Mycobacterium tuberculosis is the main reason. Then direct inoculation, direct spread, through sputum and extraction socket, fracture line. See, if the patient is having infected sputum and there is an extraction site, okay, so Mycobacterium tuberculosis, it directly spreads through the extraction site or a fracture also. So in cases of tuberculosis and all, unless until the patient has completed this tuberculosis regime of 6 months, do not go for any extractions. It may lead to tubercular osteomyelitis. Then tubercular formation in the bone, marrow reactive, subperiosteal bone formation. After that, central sedation of the bone, pus formation, and subperiosteal abscess, soft tissue and sinuses. So you will see a lumpy jaw here. Okay. In clinical feature, in mandible involvement, painless swelling, loosening of teeth, sequestrum bone, then chronic discharging sinus clinically. So this is an open tubercular lesion. The previous one was closed tubercular lesion, and this one is open tubercular lesion. Okay, with a drainage site. The lymph nodes are palpable. The diagnosis: radiograph, well-defined radiolucencies, scintigraphy, culture of pus, test for acid-fast bacilli, culture of sputum, AFB is done, then Montu test, and then the biopsy of the lesion. Okay. In management, anti-tubercular drugs, radical surgical resection to avoid recurrence. In syphilitic, maxilla is more affected than mandible. It may lead to oroenteral, oronasal communication. The sequestra is called as filary sequestra. Okay, the treatment is crystalline penicillin, 10 to 20 lakhs 6 hourly, and after late after that, penicillin 6 to 12 lakhs once in a week or bi-weekly. Then this is osteomyelitis with herpes. Okay, osteomyelitis with herpes. The patient is having herpes infection and there is a osteomyelitis in the jaw.
Yeah.
Then osteomyelitis secondary to radiation, or which is also known as osteoradio necrosis also. Okay, connective tissue become necrotic and fibrotic, and the periosteum is degeneration, bone marrow action. Then now you can see the bone exposed here, exposed bone. So there is a radiation caries also. Again, due to radiation, these are the post cases of post cancer cases. So in these cases, implants are not indicated. Okay, segmental resection and reconstruction with vascularized graft. Most of the time, they also fail. Now, this is a case reported in 1984 by my boss. So I have quoted this case also. Osteomyelitis of zygomatic arch, a very rare lesion. Osteomyelitis of temporal bone. Okay, so that's why it is this osteomyelitis is important because it mimics sometimes with the. So have you done the assignment I have given?
I have